Okay. Right, we've got no more people joining, and we have 3 talks. Looking forward to them very much in this schizophrenia section. And the first one is Marianne Beria from Cambridge with Professor Trevor Robbins. Welcome to you both. And Marianne, are you in a position to share your screen? And the format for these is 10 minutes for the presentation and then 5 minutes of questions. So as Mike said, if you want to ask a question, do feel free to raise your hand. I think that will bring you up onto the screen that I see, or type it in the chat and I can either read it for you, or it's better really if you can ask it yourself. And do say if we can all introduce ourselves as we begin.
Peter, just to remind you that the supervisors are going to give a sort of 30-second introduction at the beginning.
Yes.
Yeah.
Thanks.
So I'll go ahead then, shall I?
Please do, yes. Trevor,
Yes, okay.
The floor is yours.
Yeah, I've been blessed with some wonderful graduate students, and Marjan Beria is just one of those. She's been undertaking a very ambitious project looking at the interface between schizophrenia and OCD in the context of these bizarre side effects of clozapine therapy. And she's been focusing on a single aspect of compulsive behavior, namely checking, and hopefully also exploring the neural substrates of this symptom. Nevertheless, of course, as we all know, the pandemic has struck, and it's been very difficult in her final year to recruit the requisite number of patients for the imaging studies. So she's going to tell you a bit about what she's achieved nevertheless in this, I think, quite impressive presentation. Thank you.
Marjan, over to you.
Yes, thank you so much, Trevor, for your kind introduction. So I'm going to try to share my screen now.
Yep, we can see that.
Okay, perfect. Can you all see my screen?
Yes.
Okay, perfect. So as Trevor mentioned, my PhD project has been about understanding the obsessive compulsive symptoms in schizophrenia patients who are treated with clozapine, which is a second-generation antipsychotic medication. So about 25% of patients with schizophrenia, they also meet the diagnostic criteria for OCD. And unfortunately, these patients, they tend to have a more negative prognosis, such as higher positive and depressive symptoms, reduced social functioning, and a greater suicidal risk. So we also have the drug-induced obsessive compulsive symptoms. So throughout my talk, I'm gonna abbreviate the obsessive compulsive symptoms to OCS. And by far, the highest rates have been reported for clozapine. About 47% of all the clozapine-treated patients, they also experience OCS, which is a very high number. And this works possibly through these serotonin receptor antagonists. So it is also very important to note that the OCS severity impacts patients' well-being significantly, and that is independent of their schizophrenia symptoms, the positive and negative symptoms. So despite the importance of this issue, there have been only a few studies on the impact of this comorbidity and who is at a higher risk. And that is why we thought this is a very important topic to study during my PhD. So the objectives of my PhD were to understand the brain mechanism of obsessive compulsive symptoms using this name might sound difficult, but I'm going to explain to you what it is. It's a special type of scanner called magnetic resonance spectroscopy. And what it does, it looks like an MRI scanner, but it measures the neurochemical abnormalities. And we have a very powerful scanner in Cambridge at 7 Tesla, which means that we can measure data more accurately. So I will also use fMRI, some fMRI data to look at uncertainty, the responding to uncertainty, which is also important for obsessive compulsive symptoms. But I also have a behavioral project to look at the neuropsychological mechanism underlying the obsessive compulsive symptoms in schizophrenia patients, comparing it with OCD patients, healthy volunteers, but also pure schizophrenia patients without obsessive compulsive symptoms who are also being treated with clozapine. To do that, I used a battery of different cognitive tasks. 3 of them were developed by myself, but today I will be focusing only on one of them, which measures checking behavior. And the reason for that is because checking is one of the most important symptoms in obsessive compulsive, in schizophrenia patients who experience OCS, but also in OCD patients. And when I started my PhD, we didn't find a reliable task to measure this important behavior. And that is why I decided to design and develop a new checking paradigm. So today I will be only talking about the results of this checking task. So this is how the task works. Participants will see 2 black and white drawings of objects displayed one after another. And what they have to do is to decide if these 2 drawings of objects are the same or different. And there can be differences either in size, in angle, or they can be completely 2 different objects. It's a touch screen task. So when people think these 2 images are different, they can press on the word different on the screen. When they think they are the same, they can press on the word same on the screen. But before giving an answer, they also have a chance to press on this icon and go back and look at the images again. And this is how we measure checking behavior. After giving the answer, people also have to rate how confident they are about their answers. And this is also related to uncertainty. There are different components in this task. There are 4 different blocks, each of them measuring different components. In block 1, people don't know how they are doing because they don't receive feedback about their answers. They don't know if the answers were correct or wrong. This creates uncertainty. In block 2, feedback is optional. We can also look at the relationship between sensitivity to negative and positive feedback. In block 3, feedback is always provided, but this time people get punished for checking. And we can see who are the people that continue to check despite being punished for it. And in block 4, we can look at, we can answer the question whether checking is habitual or not. But today I will be focusing only on the block with no feedback and the block where people get punished for checking, and try to look at this functionality of checking behavior. So I'm going to show you some results now. So there are some similarities between the 2 no OCS groups, healthy volunteers and pure schizophrenia. So when we look at the relationship between confidence and rate of checking, we can see the 2 no OCS groups are very similar. They don't show any relationship between these 2 measures. But we can see that the 2 OCS groups, OCD and schizophrenia with OCS, they show a negative relationship between confidence and checking. So the less confident someone is, the more they check, or the more confident they are, the less they check. So this was a measure within the task. Now, if we correlate the measurements of confidence within the task with self-reported checking answers on an obsessive compulsive inventory, we can see the same patterns. And this is a very consistent finding because we can see that across all 4 blocks, and we can see that these are in purple and in green. We see the 2 OCS groups, schizophrenia and OCD. In red and in blue, we see always the healthy volunteers and schizophrenia without OCS. We see that this negative relationship between confidence and OCI checking, the OCI checking subscale. So it's the same between the measurements within the task, but also the self-reported measurements. However, there are also differences between these 2 groups. And when we look at the intolerance of uncertainty as a trait and its relationship with checking rate within the task, we find a positive correlation between the intolerance of uncertainty and checking behavior only in OCD patients. So it seems that OCD patients they are more sensitive to uncertainty, but it is not the case in schizophrenia patients with OCS. So another difference between these two groups is that checking seems to be dysfunctional in schizophrenia patients. So what it means is that in OCD patients where checking seems to be more functional, we see that checking improves accuracy of answers. So the more someone checks, the better, the more correct their answers become. And this is also a very consistent finding because we see that across all 4 blocks. Now, lastly, clinically, the checking task seems to be validated by the fact that the checking rate within the task is related to real life checking compulsions, or in general, obsessive compulsive compulsions measured with Vibox, which is like an interview performed by the clinicians. But we don't find this in schizophrenia patients. This might be because Vibox is not a good measure to measure the obsessive compulsive symptoms in schizophrenia patients, because they show the positive symptoms, and it's very difficult to dissociate the obsessive compulsive symptoms like intrusive thoughts from positive symptoms and like delusions. And I think we needed better measurements of obsessive compulsive symptoms in schizophrenia patients. So to conclude, the checking task successfully can distinguish checking abnormalities in both OCD patients and schizophrenia with OCS. There are similarities between the 2 groups related to confidence and checking behavior in both of the groups, but there are also differences between the groups. So intolerance of uncertainty seems to be a trait in OCD patients that is related to checking, but this was not the case in schizophrenia patients. Checking seems to be more dysfunctional in schizophrenia patients, and this might be related to other factors than the factors we find in OCD patients, such as uncertainty, intolerance. So it might be related to their deficits in making decisions. And lastly, Vibox seems to have limited utility at characterizing the severity of obsessive compulsive symptoms in schizophrenia. And we do need a better way of measuring these important symptoms in schizophrenia patients. So I also wanted to talk to you about other projects that we have. And so these findings that we have, we are also interested to find out more about the brain correlates of them. So we do that by using the 7-team MRS study that I told you at the beginning, looking at the neurochemical abnormalities in a region that we think might be important for checking and decision-making. This is just an image showing the really amazing data quality that we managed to get after our 1.5-year pilot study. In black, we have the in vivo measurements, and in red, we have the fitted model. And we can see that these 2 lines, they fit so nicely that we almost don't see the black line anymore. And this shows the good data quality that we get. But we are also interested to look at the brain function in response to uncertainty. And I'm also analyzing the data set to look at the structural features important for OCD symptoms. And I forgot to say that I've also done a literature review on PET and MRS findings in OCD, and the results are published as a book chapter, but also as a journal article. I'd like to thank all my supervisors and everyone else who has helped us in this study, and of course, Mental Health Research UK for funding my PhD and supporting me in my PhD journey. And of course, thank you all for your attention.
That's great. Thank you very much, Marjan.
Thanks. Should I stop sharing my screen?
Could you stop sharing? Yes, please. That was really impressive. Well done. You've covered a lot of ground with COVID as well, as Trevor said. So I should just perhaps comment that this is a really important clinical problem, as well as being theoretically very interesting. So it's great that you covered both those bases, really. Mike Owen, you have a question.
Yeah, thank you. That was a really interesting talk, and I agree with Peter. It's a very important and under-recognized clinical problem. My question was about differences in IQ between the groups. You talked about possibly deficits in decision making. And I wonder whether your two patient groups, schizophrenia groups, had differences in their in IQ. As you know, that cognitive impairment is a common feature of schizophrenia.
Yes, that's a very important point. So I haven't analyzed all the data that we have collected. We do have measurements of verbal IQ, and I will be looking at those data. But so I'm not sure if, because we also found differences between schizophrenia patients without obsessive compulsive symptoms. And I'm not sure if the IQ between these two groups is also different, and that would lead to checking behavior. But so hopefully next time when I present data, I would be able to give you a better answer.
Sure.
With regard to IQ.
It is a very good question, because I was wondering whether there's an effect of task difficulty. So if I find a task more difficult, I might check more.
Yes.
So it's another way of asking Mike's question, really, whether the two groups, whether the task was simply more challenging for the OCS group. So that
these are all very, very interesting questions. So the way I tried to look at this was assuming that if the task would be difficult, or because some of the trials are more difficult than others. There are different degrees of difficulty. For example, if the two images are completely different, it will be a much easier trial than if there is a small percentage in degree of angle. And the way I tried to look at this was to see if different parties, different groups, they spend more time checking on one specific trial over the others. And I didn't find differences between the number of checkings on specific trials, so between groups. It seems, based on that, I mean, I'm assuming that there was not, it was not because of the difficulty of the task, but I also need to analyze the data specifically, dividing the trials into difficulty levels, into 3 different categories of difficulty levels, and look at it, try to model the data better. But based on the analysis that I did quickly, I didn't find differences, but this might change if I look at the data more in details.
Thanks. So time's up. Thank you very much for such a great opener. And Emilio Fernandez, I see you in the audience. Thank you for your input to that.
Thank you so much.
That important work. So moving on from Marjan, we're going to move to Heather McDonald, who's accompanied by Lucia Valmaggio. Lucia, I think you're Heather's co-supervisor. And this is turning the curse into a blessing, using mindfulness to reduce schizophrenia vulnerability in psychosis-prone individuals. So over to you, Lucia.
Thank you, Peter. I'll be brief so that Heather has as much time as possible to present her findings. Heather has done a very, very good PhD, and she's just finishing writing up her results. She's done 3 studies, one with 350 people in it, one which has been published in Schizophrenia Research, one with over 100. And the study that she's going to present today is the smallest of the 3, but it's the one where we're looking at whether you can intervene with mindfulness to help people who have high schizotypy and high levels of paranoia. Over to you, Heather.
Thank you, Lucia. Okay, let me just share my screen. Okay. Yes, so I'm just going to take you through my project today. And it's supervised by Dr. Elena Antonova, Dr. Lucia Valmaggio, who you've just met, and Professor Paul Chadwick. I'm going to firstly take you just over a brief overview of the overall project aims and objectives, with a focus on the final study, which is using mindfulness-based intervention to reduce paranoia in high positive schizotypy. So positive schizotypy is a set of personality traits found in the general population, and they're thought to be reflective of the positive symptom domain of schizophrenia. And this covers unusual perceptual experiences and magical thinking, ideas of reference and suspiciousness paranoia. So higher levels of these traits are thought to predict sort of psychosis development, but suspiciousness paranoia is thought to be a key risk factor. However, on the other side of the coin, positive schizotypy is associated with increased creativity. So obviously this is a very beneficial aspect and one which we wish to preserve. And this link seems to be, or the separate lines of research that suggest that this link might be related to reduced information filtering. And in this study, we're looking at reduced habituation as an index of that. So when I talk about habituation to sensory information, if you can imagine somebody popping a balloon in the back of the room that you're in for about 10 minutes, over that 10 minutes, you will habituate to that sound because it's lost its novelty and it becomes non-salient. But if you don't habituate to that, or if you are very slow to habituate to that repetitive noise, this would indicate that you have sort of reduced sensory information filtering. So the first part of the project was looking at this interrelationship and looking at whether positive schizotypy creativity relationship is underlined by reduced habituation to sensory information. The third part of the project, the third study, comes back around to this issue of suspiciousness and paranoia as a risk factor to psychosis. And we look to use a mindfulness-based intervention to target and reduce paranoia whilst preserving conditions thought to relate to creativity. So as Lucia mentioned, the first study has now been published in schizophrenia research, but the main sort of takeaway from studies 1 and 2 was that we did indeed find positive schizotypy to relate to creativity, and aspects of the creative process seemed to be beneficial for it. However, it didn't seem to be underlined by reduced habituation as expected, at least in our sample, and this might be down to the paradigm that we used, may just not have been sensitive enough measure to detect differences. However, what was found was that suspiciousness appeared to have a dampening effect on some aspects of creativity for individuals who are high in other aspects of positive schizotypy, namely magical thinking and unusual experiences. So in addition to suspiciousness paranoia being problematic in terms of risk for psychosis, it also seems to be beneficial to reduce this in relation to creativity as well. So I'm just going to focus now on the final study, which is a mindfulness-based intervention for reduction of paranoia. So it was a randomized control trial with an active control condition, and it was focused on the acceptability and feasibility of using an online mindfulness-based intervention. I managed to recruit and complete 24 people who were high on positive schizotypy, and this was including high on paranoia, before COVID sort of took over and stopped us from recruiting anyone else. But we managed to reach the minimum kind of recommended 12 per arm for these kinds of trials. So everybody came in for baseline assessment. We had a measure of self-report general paranoid ideation. We also had an objective measure of state paranoia, and this was using virtual reality. So a massive benefit of using this kind of paradigm for measuring paranoia is that it's experimentally controlled. So this virtual reality environment was designed specifically to be neutral and non-threatening. So any paranoid appraisal from participants in relation to the avatars, you can be quite confident that it was unfounded. And this VR environment was developed by Lucia and her colleagues at KCL, and it's been shown to be a safe and valid way of measuring state paranoia in both vulnerable individuals and also the general population. So everybody was randomized to one of two conditions. The mindfulness-based intervention was using the Headspace app. And this is a meditation app. It's quite widely used and widely known. And basically it's training you to cultivate an awareness and a non-judgmental receptiveness to each passing moment. And this includes letting go of thoughts of all kinds, any sort of sticky thoughts that might be distressing. And everybody did 10 minutes of these meditations. They're guided for 40 days. The reason why 10 minutes was chosen over the traditional sort of 20 to 45-minute meditations that you'd usually find in interventions like this is because 10 minutes has been shown to be safe for people who are experiencing distressing psychosis, and this is including paranoid thoughts. So it was considered to be safe for individuals with high positive skids who may have a higher incidence of paranoid thoughts or unusual experiences and unusual beliefs. The active control was reflective journaling, and this was also via an app. So participants were asked to just reflect on their daily activities or their goals and values. It was kept quite neutral. And this app was chosen because it's quite closely matched to the Headspace app in terms of its usability and interface. It has similar sort of fun animations like Headspace does. But the key aspect was that it was trackable as well as Headspace. So both apps were trackable in terms of engagement, how many sessions participants were completing and when. And then everybody after 40 days came back for reassessment. So repeated the paranoia measures, including the VR. So retention was excellent, and as well as adherence, we had no dropouts throughout the entire 40 days. So looking at the sort of more or less the best retention rates that you usually see in these types of studies, these online studies, is about 75%. So the fact that we had no dropouts was really good. I think this may have had something to do with the protocol. So I made sure that everybody had face-to-face program orientation at baseline assessment. So this included taking them through the apps that we were going to be using, what was sort of expected of them. We set them up with an account and I gave them a demonstration of the app. And I also gave everybody sort of information leaflets, and this was physical ones as well as PDF to take home. And it was covering any general tips for using the apps and for their activity, and it included frequently asked questions or common problems that they might encounter, such as boredom or not really knowing what they're meant to be doing, or how to sit during meditation, what to do if they feel a bit irritable during meditation. So common things that people find that may contribute to obstacles of practice. I also sent everybody reminders every 10 days with sort of words of encouragement. And I also kept the lines of communication open at all times. So if they had any problems with just the app or what they were doing in general, I made sure that they were, able to contact me at any time. And also normalizing forgetting. So I was very aware that expecting participants to go away and suddenly be doing a new activity that they've never done before for 10 minutes every day for 40 days is quite a big ask. So what I didn't want people to do was to forget accidentally for 2 days or so and then kind of be discouraged and think, oh, well, I'm just going to drop out now. So at the start, I normalized that it was possible, if they forgot, not to worry about it and to just move on to the next day and just pick up where they left off. And I think that was helpful as well. So in terms of changes in paranoia, there were no group differences in self-report general paranoid ideation. However, there were reductions in mean scores for persecutory thinking during the state VR task. And this was in favor of the MBI group. So the control group didn't show really any change at all, but the mindfulness group did. And they were reliable reductions for a third of participants in the mindfulness group. So this is just basically saying that, these reductions weren't just due to chance, they were reliable reductions. And it sort of indicates that participants were less triggered by the social situation. So when they were in a state social situation, they weren't getting as many persecutory thoughts, kind of, even if their general paranoid ideation hadn't changed. In a state situation, they were less triggered. So in summary, so some aspects of positive skids-2b seem to be beneficial for creative thinking processes, namely magical thinking and unusual experiences. However, it didn't seem to be underlined by habituation of sensory information in our sample. Like I say, this might just be down to the paradigm that we used. There may be other paradigms that would be more sensitive to detect differences between participants. However, in some cases, high suspicious paranoia could dampen this positive relationship down, and taking it in addition to it being implicated in increased risk of psychosis, it's really worthwhile working to reduce this. And an online-based mindfulness intervention appears to be an acceptable and feasible way to do this in individuals with high positive schizotypy. And thank you very much for Mental Health Research UK and the Field Rose Charitable Trust for making this possible. And also thank you to my lovely supervisors who have been amazing.
Great, thank you very much, Heather. Congratulations on another terrific piece of work.
Thank you.
Could you stop sharing your screen?
Oops.
Thanks. Right, so any questions or comments? Sam Knight, you had your hand up. Oh no, you may have been clapping. Sam, and then Daniel Friedman.
Yeah, I had my hand up as well, or I wanted to put it up. I was just wondering if you looked at all of like how old were the participants, and whether you looked at all whether age would influence the effectiveness of the mindfulness.
So both groups were, there was no differences in age between the groups for the mindfulness-based intervention. So I didn't look directly at whether there were any relationships between age and mindfulness, but yeah, the groups didn't significantly differ on those factors. So I would expect that it shouldn't have had an effect.
Thanks. And Daniel?
Thanks, Heather. It's really fascinating work. Just a quick question really about the control group, because of course the sort of reflective journals may be rather helpful for processing emotions and have a sort of rather similar effect to mindfulness. So I wonder whether the paranoia in general came down in both groups, or whether the journaling was actually a helpful intervention.
There were very slight reductions in the self-report paranoia. It wasn't any, it wasn't much, and it seemed to be quite similar for both groups. It could have just been completely down to chance as well for that. But in terms of the journaling group, I definitely think that there could have been something beneficial going on there. So we didn't instruct them to journal about anything specific. I was, kind of conscious of not letting them go away and be focused on either, bad things that they're ruminating about, what's happened through the day that is bad, that might make things worse, or go in, reflect on everything that was only positive, so that they were kind of having almost like a gratitude journal, which may have been something different. But I think definitely journaling can be therapeutic, and I think it has benefits, which again is one of the reasons why it was chosen, because it wasn't specifically mindfulness based training or anything to do with mindfulness. But we thought it would be good to have something that might have a beneficial effect as well. So it was kind of a good comparison to see if there's anything specific about mindfulness, rather than just sitting for 10 minutes and kind of having a relaxing session. We did look at anxiety, and it looked like the control group had a bigger reduction in anxiety than the mindfulness group, which tells me that something was happening in the journaling condition that was beneficial. But I think one of the reasons why it may have been increased reduction in anxiety for them is because the package that was used for Headspace was managing anxiety. And in terms of the way that mindfulness trains you to become more aware of your thoughts, it may have just been that the mindfulness group didn't have any reductions because they were still very aware of any anxious thoughts that they were having, or any anxious experience that they were having. And that's not to say that they were more distressed by them, it's just that they might have been aware. But yeah, to answer your question, I definitely think there's some beneficial effects.
Thanks. And time for one last question from Mike Owen.
Yeah, so thanks. That was a good talk, and congratulations on your compliance. And it must be very challenging doing this work in a pandemic. I wanted to ask about, you said that there was a third of your group showed a reliable reduction in persecutory thinking. And I wondered whether, when you looked at the data, does this reflect a sort of a kind of heterogeneity in response, or was that a sort of quantitative threshold? Is there a sort of continuous, is the sort of response kind of continuous, or is it distinguishable into groups? You know, responders versus non-responders. I realise that the numbers are small and you know, it may not be possible to do it, but I just wondered if you had any thoughts about that.
So yes, the reliable reductions basically it's a quantitative method of saying, okay, so any reductions of, you know, taking into account the test retest reliability of the scale that you're using, it's kind of saying, okay, like this is a reduction outside of what could be expected in general variation on the scale responses. I did look at the kind of characteristics of the people who were responding. But because it's such a small group, it's difficult to say anything about whether it's anything about these specific people in terms of like age or demographics or anything that might have an impact.
But when you looked at the data, were there some people who responded and a load of others who just didn't respond at all, or was it that, you know?
Yeah, they were. Yeah, so there were some people who just didn't respond at all, and I did get some qualitative data as well to sort of maybe get an idea of why that might be. And there was some people who were saying they didn't, although they did the meditations and although they were engaging in it, they weren't really psychologically engaging with it. So during the sessions, they weren't really doing the meditation. They kind of admitted that they weren't maybe doing how, or, you know, engaging as they should have. They were just kind of sitting, thinking about their thoughts, rather than engaging in the meditation. So there's several reasons why it might have been more effective for some people and not others. But I haven't delved too deeply into the qualitative data because that'll probably come later on as a separate study.
Thanks.
Thanks. Well, congratulations again on such a terrific study, and thank you very much. So we move now to the third and final talk in the session, on to Poppy Brown, with Professor Daniel Freeman as supervisor, and this is developing our understanding and treatment of paranoia using virtual reality. So, Dan.
Thanks, Peter. It's easy to introduce Poppy. She's an outstanding DPhil student. What she's done wonderfully well is to combine understanding and treatment. So in her study, she's helped push on the understanding of how the self-concept has a role in the cause of paranoia, and use that knowledge to test new treatment techniques with precision, really. And these have been tested now with patients with persecuted delusions and are showing potentially large effects. So there's a real practical outcome of the work she's been doing. She's already published 5 studies from her PhD. But perhaps more than anything, what's very striking about Poppy is just her dedication to mental health. And I think you'll hear that in her talk. It's a very clear commitment and dedication to the area, but also she's brilliant at supporting all those other people in the team. So she supports so many other people whilst also carrying out outstanding work. She's sadly almost at the end of her PhD, but the very good news is she's been accepted for training in clinical psychology at Oxford. So she's going to do that, and I'm sure in the future she's going to be a star clinical academic researcher, I hope. So over to Poppy.
Thank you, Daniel. So I'll just share my screen. So, yeah, as Daniel said, I'm now in the 4th final year of my PhD. And today I'm going to be talking a little bit about the work I've been doing around implementation and policy. So not presenting results as such, but thinking about how I've been trying to take the research a little bit further. But firstly, a bit of a recap of what the first 3 years of my PhD focused on. So as Dan mentioned, I ran a series of randomized controlled tests of specific treatment techniques for reducing paranoia. I also used network analysis, so a special kind of statistical technique, to look at the associations between parenting behaviours and paranoia. And throughout my work, a big focus has been using virtual reality as a tool in research and clinical practice. But in my final year, I've really turned to the question of how findings can actually be implemented into services to really be actually making a difference to the people who need it. And there's 2 ways that I've been thinking about this. The first is through qualitative work, and the second is through policy work. And it's those 2 things I'll be talking about today. So one thing I know from my own work and that of my team and others in the field is that automated virtual reality therapy has the potential to allow many more people with mental health problems to receive precise one-to-one evidence-based therapy. So I designed a qualitative study to assess the feasibility of implementing virtual reality therapy into a setting where delivery of any psychological therapy is the most limited, which is psychiatric inpatient wards. So this is the Warneford Hospital where we're based in Oxford. And to set the scene, I'd just like to introduce you to Damien, who said, "We just get filled with pills. There's no talking therapies or anything like that." So Damien is one of 18,000 adults currently in a mental health hospital. Psychological therapies such as CBT are recommended for almost every mental health problem, even when problems are severe, due to its proven cost effectiveness in increasing recovery. But access to psychological therapy on inpatient wards is quite limited. Medication is the primary line of treatment in most cases. Inpatient care is nonetheless the most expensive form of care, with each bed costing up to about £180,000 per year. And this is the equivalent of supporting 44 outpatients through a community mental health team over a year. The expense of inpatient care has led to a reduction in the number of available hospital places. The number of beds for adults in England has fallen from 70,000 to just 18,000 over the past 30 years. And the consequence of this, well, firstly, there's quite a lot of pressure to meet targets for reducing bed occupancy, which in turn leads to a focus on acute symptom reduction rather than recovery and preparedness for discharge. Problems are compounded by a lack of trained staff, a reliance on agency staff, and really quite high levels of staff burnout. And so unsurprisingly, there's often limited time for much meaningful staff to patient interaction, and in general, a lack of meaningful activity of any kind for inpatients to engage with, as Dan describes. He said, "All you did was just sitting around and there was nothing for you to do, no program to keep you busy. It's not good. I stagnate." Of course, this isn't always the case. There exist many wonderful people, dedicated staff on the wards, really keen for innovation, who are trying to change and improve things for people who really do need residential care as a crucial part of their recovery. And some amazing work has been done. This slide just shows very few of these. But I think one of the challenges that remains is how we can increase the provision of psychological therapy when there are shortages of trained staff available to deliver it. And one solution to this problem may lie in virtual reality. So difficulties interacting with the social world really lie at the heart of many mental health problems. So for the people I work with psychosis, they often find everyday situations like going to a GP surgery, visiting a shopping centre or a cafe extremely frightening. In VR, it's possible to enter simulations of everyday situations while practicing therapeutic techniques that help people to feel more calm, confident, and safe. The scenarios you can see here from the Game Change virtual reality trial. So VR has a lot of advantages. Firstly, people are much more willing to enter the scenarios they find challenging because they know that it's only a simulation, it's not actually real. And that enables them to practice changing the way they think, react, and behave in these situations. But crucially, the reason VR works is that we react psychologically, emotionally, and physiologically the same in VR environments as in the corresponding real-world environment. And because of this, we know that any learning that's made in VR transfers to the real world. In addition, a crucial part of VR therapy and why it can help with the access issue is that it can be automated. So this means that in VR with you, there is a virtual therapist who can explain the therapy to you and encourage you to try things out. So this is Nick, the virtual therapist in the Game Change virtual reality trial.
Welcome to Game Change. I'm Nick. I'll be guiding you through the program. It's great to meet you. The activities you'll try in Game Change are all designed to help you feel more confident, safer, and in control around other people. Before we get started, let's introduce you to the virtual world.
So because of this automation, the therapy can be quite easy to deliver to people. A highly trained psychological therapist is not necessarily required at all times. And because of this, VR therapy is a lot cheaper to deliver. And because of this, far more people could have access to psychological therapy. So the idea is not at all to replace psychological therapy delivered by clinical psychologists and other therapists. It's an additional tool that can vastly increase access to therapy to those in need. So the Game Change trial is a multi-site randomized controlled trial of VR therapy for psychosis with many wonderful and important collaborators I'd like to acknowledge, so particularly the McPinn Foundation, NIHR Mindtech, and many others. So in my quantitative study that's looking at the implementation of VR therapy onto inpatient wards, I'm running focus groups with NHS staff and patients on wards at 5 mental health trusts across England. And in these groups, I demo the VR Game Change therapy and find out what people think about it. There's sort of 3 key objectives. Firstly, to explore staff and patient expectations of VR therapy before they've tried it, and then to get their feedback on after they've tried it. Secondly, to apply an implementation framework. So I'm using the NAS framework to assess feasibility of adoption. And finally, to identify if there are any differences across those 5 sites in England for feasibility of implementation. And again, I've been very fortunate to collaborate with Mindtech and McPinn on this study. So I began running focus groups just before the pandemic began last March, and of course had to pause since then. So I'm not able to share the results just yet, but I will just share a quote from one individual who reflected on what it was like to try the VR on the ward. So this is Simon, who said, "That was more than real. Although you sort of know that it's virtual reality, it does feel real. It's quite bizarre. I already feel as though I've been out today by just being in that experience." And the protocol for this paper is published in Journal of Medical Internet Research. So upon having to pause the study, I then turned instead to thinking about mental health policy. So that's a second way we can think about kind of taking research a bit further. So I spent several months working in the mental health policy team of the Department of Health and Social Care, working very closely with NHS England Improvement and Public Health England. I'm very grateful to Mental Health Research UK for supporting me to do this secondment. So a bit of a brief summary of what it was like, what I was doing. So essentially I was working as a civil servant, and most civil servants are generalists who have transferable skills across departments. They don't necessarily arrive in a team with domain-specific knowledge. Some examples of the work I was doing was working on a cross-government mental health action plan to respond to the mental health needs of the population following the pandemic. Also working on a mental health and wellbeing impact assessment. So that's for when other departments introduce new policies, creating a tool where they can actually think about how is that policy going to impact mental health, because we know mental health has many social environment determinants. I also led my team's engagement with stakeholders, and in particular, I tried to increase our engagement with experts by experience, so people with, particularly with personal experience of mental illness. I would write submissions for ministers and Secretary of State for Health, and because I came from an academic background, I tended to lead our team's work on any evidence reviews or notes that needed doing. So for me, it was a really insightful experience. I felt I was really able to contribute to a lot of important work, and now have a much better understanding of how to stay engaged with mental health policy and hopefully continue contributing to it in the future. So finally, just like to say thank you to my supervisors, Daniel and Felicity, and also to 2 members of my team who particularly contributed to the qualitative study, Sinead Lamb and Lena Rosebrook, and of course, a huge thank you to Mental Health Research UK.
Super, thank you very much, Poppy. That was very interesting and reflective account of what you've been doing. Any comments or questions? Laura.
Hi there. Hi, I'm one of the co-founding trustees of MHR UK. Yeah, I just wanted to say, I think it's absolutely brilliant that you went into policy. I think that's fantastic, because so often, you know, people are really into their subject scientifically, but then they don't think, how can that be applied? So well done, brilliant. And I really hope that it's also had a massive impact on your team members in the civil service. Because as you say, they are generalists, and it's great that an expert was able to go in and sort of teach them a bit more. I just wanted to ask about, obviously you said that there was automation. So it was possible to run this program and the patients could kind of go through the program themselves. And I know that you also said that it was created to be non-disturbing. So it was, you know, quite a sort of calm scenario. But what if a patient did have heightened emotions and did feel disturbed, if there isn't a psychologist who's there with them? I know you were working in the hospital setting, so there would be nurses nearby or whatever, but how was it? How did you organize it so there would be a nurse nearby, close at hand when each patient was going through this, or how did it work?
Yeah, sorry. So what I missed out and what I should have said is that there is always someone in the room delivering the therapy, but instead of that necessarily being a clinical psychologist or other therapist, it can be someone like a peer supporter or a graduate psychologist, a healthcare assistant. It can be, I guess, a non-specialist workforce, or anyone really can deliver it. So there is always someone present in the room to kind of guide them through, you know, help with the tech, or exactly, you know, if someone's becoming distressed, help manage that. But there's a lot more diversity of who that person can be. And so, yeah, on the wards, I was just demoing. I wasn't providing therapy on the wards. It was more just a kind of demo, and I was there the whole time, as was a clinical psychologist. So yeah, there is always someone in the room with the people we work with, but I guess there are many more people that person can be.
Okay, great. And then just one follow-up question. I'm actually a mental health barrister. And I've seen a lot of patients on various different wards, high security and whatever, and they pretty much all complained about boredom and, you know, not having really interesting activities. So I can imagine that people would have engaged with this probably as it's a novelty factor. You know, they're like, oh, great, something to take my mind off, you know, the boredom. If this became like a normal therapy, do you think there would be a drop-off in interest? Or is that something you haven't considered, or you can't really consider because we're just not there yet?
I mean, I think that's one of the questions we're trying to think about, and that's why I'm kind of doing a qualitative study to start off with and really look at, you know, if this was available, what would it look like and what are the barriers? And that could be one barrier to it being sort of continually adopted. Again, it's going to vary depending on the ward. You know, acute wards, there's quite high turnover of people on the wards. Whereas, you know, rehabilitation wards, they're there for a lot longer. And I think there's a lot of variation in what VR can be used for. It can, you know, we've got this kind of structured cognitive therapy, game change, but, you know, there's also mindfulness activities or relaxation exercises you can do in VR. So I think with the diversity of it, it is something that could be used, and because, as you say, boredom is a big problem, I think it is something that would, I would like to think it would be used continually, but that is something we're trying to find out a little bit about in this study. But of course, it's very difficult to know for sure until you actually go ahead and implement it and see what happens. But yeah, I think there's a lot of potential there.
Great. And is a pilot study likely? Do you think the government will adopt a pilot study?
Difficult to say.
Well done. Thank you. Thank you for your presentation. Really interesting.
Thank you.
Thanks. Mike, is your hand up or is that a residual hand?
No, my hand is up, but
Good.
If someone else has a question, my question really was whether you got a sense in your time in the Department of Health about whether you would be kind of pushing an open door with VR technology, or whether you thought there were sort of barriers and that you would need to break down, and if so, what they were.
I think it's definitely an open door, particularly, you know, as we all know with COVID, the kind of digital tech has become much bigger. Nadine Dorries, the Minister for Mental Health, is very keen on digital tech, very keen on promoting that. And I gave a few talks about our work and about VR. And again, I know Tim Kendall, Clinical Director for NHS England, is aware of VR and very keen on it. So I think it is an open door, definitely. There are always barriers in policy. Everything can take a very long time and it is never easy. But I think there's definitely a lot of potential there.
Good. I'm sure you've oiled the hinges of the local door as well. Thank you.
Hopefully.
Any other comments or questions?
I have a question, if I might.
Please do. Go ahead, Lucia.
Hi, thank you, Poppy. Great talk. Just in the qualitative work, are you asking about negative experiences as well? We started doing that, and that has helped us improving what we offer. I was wondering whether you came across the same level of, it's not always positive.
Yeah, absolutely. We've been very careful in the topic guide we're really finding out what's good, what's bad. We want to know everything, and it's deliberately designed to ensure that we get really quite honest feedback to find out what people don't like. And we could find that actually people say, no, this isn't going to work here. Very willing to find that out. That hasn't been generally what people have said. We've had really positive response, really insightful thoughts from patients. But definitely we're trying to find out, what needs to be improved, and, realistically, how can this actually work? What do we really need to think about? What are the challenges? What are going to be the problems? That's definitely a big part of the study.
Thank you.
Good. Well, thank you very much. We've had 3 terrific talks. For the supporters in the room, it's worth reminding them that it's the supervisors' applications that get judged, and the successful supervisors, it's then up to them to match their projects with students. And clearly the supervisors have done a tremendous job in that step with 3 outstanding students. So well done to all of you for what you've achieved during your scholarships. Thank you for excellent presentations, and good luck in the future. So we've got about 3 minutes or so for a quick stretch before we rejoin in the main room, and I'm afraid you've got more of me there. So see you in a few minutes.
What happens now? Do we have to, do we stay in the breakout room, do you know?
I think we'll automatically get returned shortly.
Yeah, I think when the 5 minutes is up, we are going to return automatically.
That's normally how it works.
Very good. It's good to have some virtual reality expertise on this call, I tell you. I just had to rush off and let the dog out.
Marjan, can I ask you a question? Is that all right?
Yes.
I didn't get one earlier. I just wanted to ask you, sorry, I'm not putting any pressure on you, but I'm genuinely interested. It's not, I'm not testing you. How certain were you that the patients on clozapine didn't have OCD symptoms beforehand? How did you?
So Dr. Fernandez, he is their treating consultant. Mm-hmm. So he would find the patients for us. So he knows their history. Okay. And he is the person actually putting them on clozapine. Mm-hmm. And we only recruited patients that were on clozapine for 6 months or 1 year, longer than 6 months or 1 year, because it takes more than 6 months for the symptoms to develop after they start clozapine. Yeah. So that's how we make sure that they did not have OCD symptoms before starting clozapine.
You said, I think the figure you said was 49%. Is that right? Developed OCD?
Actually, that was a publication by Dr. Fernandez, but in our sample, the percentage was 66%. It was even higher.
That's terrible. I mean, my personal view as a barrister is that it's just appalling that people are being forced to take these medications. I mean, the medications are just, I have a particular interest in schizophrenia because my patients with schizophrenia were in hospital, often in high secure hospitals for well over a decade. There was just nothing for them because I think it was something like a third, 30% roughly didn't really react to any of the treatments that were available. Yeah. So, I mean, I feel desperately sad for them. They're just going to have bad quality of life their entire life. But yes. Clozapine, I understand clozapine does work on a lot of patients who don't respond to other treatments. But to have these terrible side effects, it's just, and then to be forced to take the medication because you're an inpatient and, the mental health legislation insists that you take it. The solution, in my view, is we need better treatments, which is why I set up MHR UK with Claire and John. I mean, that's why I set it up. I was so frustrated for my own patients.
Yes.
So, yeah, I mean,